I'd like to thank the organizers, Jack Koch and Artie Kavanaugh, for the kind invitation to come to RheumNow Live and present this talk. I am not at RheumNow Live, but I'm happy to talk to you about the prevention of rheumatoid arthritis today. And these are my disclosures. And this is the outline of my short talk. We'll talk about the phases preceding RA, and when we talk about prevention of RA, we're talking about prevention of RA in whom? We'll talk about genetic risk factors, family history, and environmental and potentially modifiable risk factors for RA, as well as potential interventions to prevent RA. So the key question that you can think about during this talk is, to approximately what extent can RA risk currently be correctly assessed given genetic factors, environmental and lifestyle factors, and their interactions? Where are we today? Is it 20%, 50%? 75% or 90% of the risk can correctly be predicted or assessed, just to think about. So this is an epidemiologist's view of how genes and the environment interact in RA pathogenesis. So you have your genes that you inherit from your parents, and you have whatever assortment of genes for whatever risk of chronic disease you inherit, and then you have many different environmental exposures during your lifetime. Starts in utero, and then during my career, we've studied a lot of these, and they are risk factors for RA, the ones I put here: cigarette smoke and sex hormones, viruses, air pollution, silica. Some of these may go back and cause epigenetic changes to the genes and alter the way the genes are expressed. And then in some unfortunate people who have kind of the wrong combination of RA risk genes and RA risk factor and environmental exposures, they may develop some early immune dysregulation and subclinical disease with upregulation of inflammatory cytokines and autoantibodies. And then a few of these people will probably go on to develop clinical RA as well. And an expanded view of this is that you have your genetic risk in the early phase. A percentage of people go on to phase 2 with asymptomatic autoimmunity and inflammation. Another percent go on to early symptoms, and then a percent to the final phase of meeting classification criteria or meeting diagnosis. We don't know exactly what the proportions of these people are, and we don't know what proportion may, go the other way and remit or not progress. And along the way, as I said, you have your genetic risk at first, and then some benign autoantibodies and cytokines and chemokines may develop, and then later more pathogenic autoantibodies maybe. There are environmental exposures all along the way. Epigenetic changes could happen all along the way. And then when we talk about risk prediction or prevention, we can talk about it from, phase 1, phase 2, or phase 3. So first about RA risk genes. The number of risk genes is fast expanding due to genome-wide association studies, GWAS. Here I've said there are 124 significant loci and 35 novel loci, and that number just continues to grow. Most of these big GWAS studies were done in European or Asian ancestry populations, and we direly need large studies in more diverse populations. And a lot of the risk is still associated with HLA genes. A lot of these more recently discovered risk genes have small odds ratios. But now with these big international genetics consortiums, we can detect even these small increased or decreased odds ratios. So the first case that I'll give you today is that of a 58-year-old man who presents for evaluation of hand arthralgias worsening for the past year. He's had no synovitis on exam, but he is tender across MCP 2, 3, and 4 bilaterally. And he admits to more fatigue, but it's been a really stressful time. Of course, it's been stressful for everyone. And he's not sleeping well. He is stiff in the morning up to 45 minutes. He's been taking Tylenol with only short-term relief. And nothing else on review assistance that you uncover. So the question for you is this new onset RA? And what can you do to prevent RA in this gentleman? So genetics can help to diagnose RA earlier among those presenting with synovitis. This gentleman only had arthralgias, not clear synovitis. But in a past study that we did here at the Brigham, we identified a lot of people who the physician that wasn't sure what kind of inflammatory arthritis they might be developing. They had some synovitis, but they didn't really know what they were doing. So they took their genotype information. They also happened to have their blood collected, and so we could do genotyping on them. They had this synovitis, and then Rachel Knevel and Shomro Chowdhury worked on what they called GPROB. which was taking genome-wide association scan data and developing polygenic risk scores for each of these conditions, 5 different kinds of inflammatory arthritis. RA is in there, lupus, spondyloarthropathy, psoriatic arthropathy, and gout, and then running the patient through this GPROB computer to see where their genes lined up. And so this patient X would be more of a lupus phenotype, and patient Y more of a spondyloarthropathy, and patient Z more of gout. And so after they did this, they found that the initial diagnosis by the rheumatologist was only 35% correct for the ultimate diagnosis, and that improved to 51% after throwing in the genetic information. So a little bit of improved classification and predicting earlier whether the patient's going to develop rheumatoid arthritis. But there are many other biomarkers beyond genetics that we use for accurately predicting who's at risk for RA. And these are clinical biomarkers that you use all the time: anti-CCP or ACPA, rheumatoid factor, C-reactive protein, erythrocyte sedimentation rate, ESR. And then imaging biomarkers, ultrasound and MRI, and then a load of research potential biomarkers, and more coming, autoantibodies with fine specificity to the ACPAs, or glycosylated ACPAs, anti-CARB P, anti-PAD. There are epigenetic changes that can now be identified that maybe give us clues to risk for RA, different inflammatory markers and metabolomics and lipidomics, matrix metalloproteins, adipokines, single cell. Immunophenotyping is really exciting, and I could go on, and there are studies every day about new biomarkers that may help us hone our risk prediction, as well as shed a lot of light into RA pathogenesis. And this is a past study from the Nurses' Health Study, where we have looked at these fine specificity of kind of novel ACPAs and the number of ACPAs. And here, working from left to right, these are the women who later developed RA compared to controls who didn't, and their blood samples were collected up to 14 to 17 years prior to their onset of RA. Compared to controls, the cases there over time have this increase and the steady increase, and then from about 6 to 8 years, it really goes up, of the number of different ACPAs that are positive versus the controls stay down here in this low range. So this is evidence of epitope spreading and increased numbers of ACPAs preceding the diagnosis here at time 0 of rheumatoid arthritis. And there are many past studies of anti-CCP or ACPA predicting RA. It really is one of the strongest predictors. There are studies from healthy blood donors showing that having rheumatoid factor and CCP, 69% of those patients developed RA within 5 years. In another healthy population of people visiting a health fair, if they had CCP greater than 2 times the upper limit of normal, 70% developed RA within 3 years. In RA family members, this is even higher. So if you're CCP positive, 61% developed RA within 5 years, and the hazard ratio was 207 versus those who are CCP negative. So that's a pretty exciting hazard ratio. Among people who had arthralgia, so early symptoms like our gentleman in case 1, any anti-CCP would increase the risk for developing RA to 30% within 3 years, and a high titer CCP would increase the risk 50%. 50% of people, developed RA within 3 years. And then among people who are already anti-CCP positive having a high titer, 46% of these people developed RA within 5 years, and that increased the hazard ratio almost 5 times versus having a low titer CCP. So definitely anti-CCP is a very strong risk factor for developing future RA. So let's make case 1 just a little different. So it's the same case here, but now I'm telling you he's anti-CCP positive and his ESR is elevated. So now you have even more suspicion that he may be developing RA. But still he only has arthralgias and synovitis, and you're catching him very early. So several years ago, Annette Vanderhelm Van Mil and Tom Wiesinger and Leiden developed the Leiden prediction rule for undifferentiated arthritis becoming rheumatoid arthritis. So that's a little bit like this man. In the Leiden early arthritis clinic, they saw 570 patients with undifferentiated arthritis, and then they followed them for progression to RA or another diagnosis at 1 year. And they came up with a prediction rule of 9 variables that you would probably come up with too. Age, sex, symptom location, having morning stiffness, tender and swollen joint counts, a high CRP, rheumatoid factor, and ACPA. And their area under the curve, the AUC values for their initial rule was very good at 0.89, and then they did cross-validation and external validation. It was really very, very good at 0.97. So using this rule, which I think most of us kind of have in the back of our head probably when we see these patients, we can really predict who might be developing rheumatoid arthritis if we have all of this information when they first present with their undifferentiated arthritis. And so that leads us to the ability to do potentially RA prevention trials. We have this man who's developing RA. What do we do for him? So these are all European trials. There are 4 trials that have been completed now, and they're very, interesting, different ideas. So in the Dutch DEX trial, they identified a population of people who were rheumatoid factor positive and ACPA positive and had arthralgias, gave them 2 doses of 100 milligrams of dexamethasone, and compared to placebo, and there was no difference in progression to RA, but there were lower autoantibody levels at the end of the trial. In the Prairie trial, they identified rheumatoid factor positive and ACPA positive patients with arthralgias. They also had high CRP or subclinical synovitis on the ultrasound or MRI, and they gave them 1 big dose of rituximab, 1,000 milligrams IV, or placebo, and then followed them for quite a few years. And they found that there was a delayed onset of inflammatory arthritis at 12 months, but then by 3 years, there was no overall difference in progression of inflammatory arthritis. And I'll show you those curves in a second. In the STAP RA trial, they identified people who had rheumatoid factor or ACPA positivity or high ACPA arthralgias, and they had calculated their risk of RA as being greater than or equal to 55% in 3 years. And they used atorvastatin, which is interesting because of its maybe immunomodulatory, anti-inflammatory properties, and there was no significant difference in progression to RA in 14 months. And in the latest trial, which I think has not yet been published because I've been looking for it, but was presented at ACR in 2021 as an abstract, the ARIA trial, they enrolled ACPA positive subjects who also had subclinical MRI joint inflammation and gave them abatacept for 6 months, and then versus placebo, and then they followed people for another year after that. And they found decreased progression to RA at then the 1.5-year mark in the abatacept group, 8% versus the placebo group of 35%. And this was very statistically significant, and we're looking forward to that manuscript. So these are results of the Prairie trial where they gave a single dose of 1,000 milligrams of rituximab at time 0 here, and then the Kaplan-Meier curve shows the primary endpoint of arthritis development over time, and the blue is the intervention group, and the red is the placebo group here, and they're developing RA a bit faster, and at 12 months, you can see there's fewer cases of RA in the rituximab group than the placebo, and they're saying that at the 25th percentile, there's a difference of 12 months here, 12 to 24, between the two groups, but then when you get to this 36-month mark, there's really no difference anymore. So it delayed, 1 dose of rituximab delayed the onset of RA, which is pretty exciting. And there are more RA prevention trials ongoing. There's the Attributable also trial, also using abatacept. There's a treat earlier trial, methylprednisolone and methotrexate. And there's the Stop RA trial led by Kevin Dean, and we're doing that at the Brewing as well using hydroxychloroquine. So, poll question 1 to keep you on your toes. This is an easy question, but do you see patients who are concerned about their own or family members' risk of developing RA? That a lot of people do. You can just answer to yourself, yes or no. So case 2 would be such a case, a 32-year-old woman who has a strong family history of RA. And she's coming to see you and says, that her mother and older sister both have seropositive, erosive, pretty severe RA. Her father has diabetes and psoriasis, and her younger brother has Crohn's disease. So what is her lifetime risk of developing RA? What do you tell her? And then also she wants to know what can be done. So what can be done to prevent her from getting RA? Is there any targeted prevention for patients like this who are at high risk? So as I mentioned, we've studied a lot of modifiable lifestyle, behavioral, and environmental factors for RA over the years. And in the Nurses' Health Study, Women's Health Study, other related cohorts, and others have as well, and other cohorts. So we can put them into buckets of the factors that we've shown that are definitely related to increased risk of RA. And those include cigarette smoking, a very strong risk factor, silica dust, solvents, mineral oil, air pollution, and living close to a major roadway. In the United States, living in the north was associated, and the Midwest are associated with a higher risk than living in the West. Being of low socioeconomic status, obesity is associated, sugar-sweetened beverages and poor diet. Periodontitis has been associated with risk of RA, as well as post-traumatic stress disorder and depression. And then actually on the flip side, we've shown that higher exposure to UV light and longer-term breastfeeding of one's own children, babies, are associated with decreased risk, as is moderate alcohol intake, which is really the sweet spot of like a half a drink a day on average. High fish intake, following a healthy diet, that's the alternative healthy eating index, or the anti-inflammatory diet we've studied in the Nurses' Health Study, and increased physical activity and higher vitamin D levels, also associated with decreased risk. And then there was no association with antioxidant vitamin intake and decaffeinated coffee and protein and red meat intake. So we've used this and put these all together, and this is a recent risk prediction model paper, but we've done this in the past as well, and also with the epidemiologic investigations of RA group and cohort in Sweden to validate these models. So here are some models for prediction of RA among women, and these were healthy women at the start. May not work exactly the same in men, because this was in the Nurses' Health Study cohorts. But here are the different lines. The red is environmental factors and lifestyle factors only. And then we add in the genetic factors, an RA-weighted genetic risk score, and gene-environment interactions. And that brings up the area under the curve to 0.72. When we added in metabolites that we found associated with RA, just environment and metabolites, not great, didn't help so much. And then we have a final model where we added the metabolites with the environment and genetic and gene environment interactions. We got it up to about 0.74. So that was the question I asked you, where are we today? We're at about 75% prediction. In other models, we get it to about 77% under the curve, ability to accurately predict from what we have about risk of RA. And this is in women, but we have had some of our models validated in men as well. So family history, also very, very important. So family history encompasses both genetic and shared environmental factors. So we know that monozygotic twin concordance rates for RA are between 12 and 15%, and the heritability in twin studies is about 53 to 65%, so high heritability, but not 100%. The inheritance risk ratios, or the lambda, the genetic risk in first-degree relatives, is between 2.8 and 4.5. And then we also know that smoking is highly correlated with parental smoking, so one's own smoking with parental, and probably with your sibling smoking, so that runs in families. And body mass index also is highly correlated among family members, as are other exposures. And people grow up in the same neighborhoods, they have the same socioeconomic status, they have the same exposure to air pollution, etc. Lots of shared environmental factors. This is one of the most comprehensive studies of family history and RA risk. And of course, Sweden is an epidemiologic paradise. And here, Haminki and colleagues compiled data from a nationwide Swedish registry and national database of hospital discharges, all indexed by diagnoses. And they compared the risk of RA categorized by family history of a variety of different autoimmune and inflammatory diseases. And they adjusted for age group, sex, time period, region, and socioeconomic status. And first, among people who had an affected family member with RA, depending on who that was, they looked at the standardized incidence rates for RA compared to one being no increase. So having a parent, a sibling, a twin, a parent and sibling, or a spouse. So that the spouse is kind of a ringer here. Parent and sibling, increase the risk by 9, and even having a spouse increase the risk a little bit. Maybe that's because of shared environmental factors. And then they looked at other autoimmune diseases and the standardized incidence rates for RA and found that other autoimmune diseases, including ankylosing spondylitis, scleroderma, Sjogren's, the diseases we see, all kind of associated with increased risk of developing RA as well. And we know that autoimmune disease risk does run together. And here it's been kind of quantified. So poll question 2 is, do you feel confident in your ability to assess a patient's risk of developing RA? And that is also for your own self-knowledge. You can answer quietly to yourselves about yes or no. Hopefully at the end of this you will. So this is our 32-year-old woman who has a strong family history of RA. So what is her lifetime risk of RA? Can you put it into a calculator? And what can be done to prevent her from getting RA? So we talk about population attributable risk for RA. And these are data also from the Nurses' Health Study. So these are generalizable to women, maybe not so much to men. So here, a few years ago, Jeff Sparks led this study where he looked at the population attributable risk for known risk factors for RA among people in the general population and then among first-degree relatives, people who said they had a family history of RA or lupus in the family. So overall, the population attributable risk, the portion of the risk in the population that's attributable to that risk factor was 21% for RA, 14% for smoking, higher in first-degree relatives, no alcohol intake being the risk factor here, very low risk alcohol is 12%, increased BMI 9%, nulliparity and low breastfeeding because long-term breastfeeding is protective, was 15%. And then, so basically, most of these, except for alcohol, had higher population attributable risk in first-degree relatives. And if you put them all together, the population attributable risk in first-degree relatives is up to 46% in all modifiable factors, 41% in the general population. And then the genetic variants by themselves, too, in contrast, explain about 18% of the variance in RA risk. So taking this knowledge a few years ago, this was a trial led by Beth Carlson here at the Brigham, which we participated in, recruiting first-degree relatives of RA patients. So here we recruited them, and they were randomized to 3 different arms. The first arm was the attention control, where we told patients that they had a risk of RA because they had a family member, and they were given a pamphlet from the Arthritis Foundation about RA. The second group got the pre-RA personalized risk estimator, and I'll show you what that looks like in a second. A little more detailed information about their personal risk for developing RA. And the third arm got the Cadillac intervention of the pre-RA risk estimator and some individual education and counseling. And then we followed patients for baseline, and we looked at outcomes 6 weeks, 6 months, and 12 months post-intervention. And we continue to follow some of these patients for their long-term early RA outcomes. So this is what the pre-RA calculator looked like. Patients went online on the calculator. They input their information, height, weight, family history, etc., like any other website these days. And then it would give them this nice kind of thermometer of their risk, how their risk would be compared to people with lowest risk or highest risk. And then you could click different boxes and watch your own risk go down. So looking at the population attributable risk in yourself of, your different risk factors. If you quit smoking, and here there was a lot about periodontal disease and brushing your teeth, et cetera, or eating more fish, if that was a risk factor, then you could decrease your risk. And then it would give you an overall personal risk of developing RA as percentile. So here, if your risk was 19%, it was explaining that out of 100 women just like you, 19 would develop RA, and the left 81 would not. And then the primary outcome of the trial was actually not the development of RA in this case, but it was changing their motivation to work on their risk factors in something called the trans-theoretical model, working from pre-contemplation to contemplation, preparation, action, maintenance, up the ladder. So if they, no matter where you started, and there was a separate ladder for each behavior, no matter where you started, then you could move up, and you could ideally get to taking action to lead a healthier lifestyle and decrease my RA risk. And these are the results. So here, this is immediately a baseline, and then at 6 weeks and 6 months, there was sustained effect, and there was increased motivation to change behaviors from the baseline in the comparison group. They got on the pamphlet, and both of the pre-RA intervention groups together. So this is great, and we actually now know how we could motivate our patients with a little bit of personalized risk factor education to work on their risk factors that are risk factors for RA and risk factors for a lot of other diseases as well. So case 3 is really just, what about everybody else in the general population if they don't know their particular risk of developing RA? Overall, women have a 3.6% lifetime risk of developing RA, and men have a 1.7% lifetime risk of developing RA. So should we target this intervention to people who are at high risk, or just prevent RA in everyone, knowing that a lot of people are at risk, and that most of these risk factors are things that people could improve in their lifestyle and have a healthier lifestyle, which would improve multiple disease risks. So to argue that point, we recently looked at what's called the Healthy Lifestyle Healthy Lifestyle Index Score, HLIS. And so the Healthy Lifestyle Index Score is an index of 5 healthy behaviors, which are here at the bottom: drinking alcohol in moderation, maintaining a healthy body weight, distant or never smoking, so quit smoking and put it in the past, or never smoke, following a healthy diet, which is the alternative healthy eating index, and being in the top 40% of that index, and having a healthy level of physical activity. And in the past, very similar results have been found for things like cardiovascular disease and cancer. But here we show that in any order that you improve your lifestyle compared to these people here who have the most unhealthy lifestyle and don't have any of these healthy behaviors, improving your lifestyle by any one of these, 1, 2, 3, 4, 5, your risk continues to go down. And the population attributable risk here for having any 4 out of 5 of the healthy behaviors was 37% of the risk of RA could be reduced. And here the hazard ratio for developing RA then gets down to just 0.42, which is very exciting. And it's a strong public health message that risk of RA can be decreased by following a healthy lifestyle. And RA, joins other diseases like cardiovascular disease, cancer, other things we know are associated with having a healthy lifestyle, or decreased risk associated with healthy lifestyle. And I just have to mention that a lot of these RA-related risk factors are also social determinants of health. And we see disparities, and I mentioned that socioeconomic status is a risk factor, or low socioeconomic status is a risk factor for RA. And this is probably why, because when we think about the social determinants of health, food access and quality, housing and stress, which is associated with RA, and then there's job opportunities, medical literacy, work stability, depression, trauma, institutionalized racism, the neighborhood and built environment, air pollution, noise pollution, and then all these healthy behaviors, dietary quality, alcohol intake, and healthcare. They're all related to RA risk. So really, I think I'm arguing that we need to improve our society to improve or to decrease risk of RA and decrease risk of many chronic diseases in the entire population. And maybe many of these exposures fan the flames of brewing RA by increasing chronic systemic inflammation. So we don't know exactly how the genes and the environment interact, but it could be that they interact a little bit non-specifically, that obesity, smoking, silica exposure, child abuse, and PTSD all have been related to increasing CRP and interleukins 6, IL-6, TNF-alpha, MCD1 biomarkers of inflammation, whereas alcohol intake, interestingly, has been shown to decrease these. So maybe these really stoke the flames of some brewing RA and other chronic diseases. So briefly, I want to introduce the results of the VITAL trial, which is vitamin D and omega-3 trial. It was a very large trial. It's actually, we're continuing to follow these people now in open label extension. There were 25,871 adults, men aged 50 and over, and women aged 55 and older. They were first randomized to vitamin D or 2,000 international units a day or placebo. And then in a 2x2 factorial design, they were again randomized to omega-3 fatty acids or placebo within those arms. And participants were recruited from their residences across the United States. They were healthy individuals. Over 20% of the population was African American. The primary outcomes of the initial trial when it was set up were for cancer and cardiovascular disease, and those results were published in the New England Journal in 2019 here. And then we were lucky to get actually 2 grants to study autoimmune disease outcomes in this population from the get-go, from their randomization. And overall, the confirmed incident autoimmune diseases to date, we've seen, this was in 5.3 years of randomized follow-up. Among those in the active group for vitamin D versus the placebo vitamin D, there were fewer cases, and the hazard ratio did meet statistical significance. And then in the omega-3 fatty acid group, there were also fewer cases, but it missed statistical significance. And we didn't see any interactions or synergy between the 2 supplements. We didn't see that taking both was better than taking just one. We did see an interaction of vitamin D with BMI and a stronger effect at low body mass index. And we saw an interaction of the omega-3 fatty acid intake with family history of autoimmune disease and a stronger effect there. The safety has been previously reported, and we didn't see any significant differences in adverse effects in the intervention versus the placebo arms. And here, when we break it into the 4 factorial groups, remember it's a 2x2 factorial design, you can see that, and these are the confirmed incident autoimmune diseases, and these are the confirmed and probable groups. All of the intervention groups, the 3 intervention groups, really reduced the risk of developing any autoimmune disease. There were many different autoimmune diseases over time, and this was true in the probable cases as well, and here they all hit significance. And these are the results that I really wanted to show you about incident RA, which looks very exciting for both vitamin D and the omega-3 fatty acid intervention, that the point estimates here, the hazard ratios, are really reduced for both interventions, for the confirmed and improbable cases. The confidence intervals are wide with small numbers of cases, but as I said, we're continuing to follow these people, and it is looking good, so stay tuned. So in summary, where are we with our efforts to prevent rheumatoid arthritis? As I've reviewed, we have identified many different genetic and environmental risk factors that are associated with this, which are now allowing targeted intervention. And new biomarkers may be even better than ACPA. Who knows? These interventions can be targeted at those with early symptoms and very high risk of developing RA, which we sometimes call imminent RA. They can be targeted at those with a strong family history or genetics or modifiable risk factors, or they can be targeted at the general public, as was the VITAL trial. Abatacept and rituximab have been shown in trials to maybe forestall RA in those with early symptoms, so that's exciting. And then a few lifestyle interventions may decrease RA risk as well. I've shown you results for smoking cessation, weight loss, physical activity, decreased exposure to air pollution and toxins, moderate alcohol, perhaps others. So lots to discuss with your patients who are worried about their risk of developing RA. And then vitamin D and fish oil are 2 very promising non-toxic interventions to prevent RA and other autoimmune diseases as well. Will they work as well in high-risk populations? We don't know. Of course, the VITAL trial was all comers, general public. We don't know who was especially high risk. And we don't know if they'll work as well in those with early symptoms, because everybody was healthy and we don't know if any of them had early symptoms when they started on these supplements. So key takeaways from this quick half-hour presentation. RA risk prediction is becoming increasingly possible. Specific environmental and lifestyle factors are strongly associated with RA risk, and we can and we should counsel our patients at high risk about them. RA prevention trials in individuals with early symptoms already are ongoing, and RA prevention trials for those at increased risk without symptoms may be even more interesting and important. And with that, I will thank you, give a big thanks to many of my co-investigators over the years, and thanks to my funding as well.